Welcome to this webinar on filtering through the impact of chronic kidney disease on cardiovascular disease. I'm Garry Jennings, and we're delighted to have you all attending from around Australia and indeed around the world. I'll begin by an acknowledgement of country, which is going to be particularly relevant with our discussions tonight. We acknowledge the traditional owners and custodians of country, not just throughout Australia, but around all of the countries attending this meeting, and their continuing connection to land, waters and community. We pay our respects to them, to their cultures and to their elders, past, present and future. So we have a joint meeting tonight on behalf of the World Heart Federation and the National Heart Federation of Australia, and this is World Heart Day. And if anybody is wondering why we would be having something on kidney disease on World Heart Day, I think that will definitely be revealed in the course of our discussions tonight. We've got a wonderful panel for you. You will have seen it in the leaflets that preceded the meeting. George Bakris from Chicago, Merlin Thomas from Melbourne, William Majoni from the Northern Territory, from Darwin, and Alison Edwards from South Australia. And I think together they'll be able to bring you some perspectives on the management of renal disease and its relationship to heart disease in the community, and all of the most recent information in the light of the sort of trials that we've got indicating different treatments, different ways of identifying people at risk. And I'm going to begin firstly with a little bit of housekeeping. You can pose questions. We've already got a lot of questions from the almost 1,500 of you that have registered for this meeting, but feel free at any time to put a question into the Q&A box. We won't be able to get through them all, but we'll do our very best to do that in the course of, if not during the meeting, then subsequently. But we're going to begin with three presentations. Brief presentations just to set the scene, and the first one will be Professor Merlin Thomas, and he's going to talk about the role of early detection of renal risk factors for cardiovascular disease. So he's going to be talking about risk assessment, and really look forward to hearing that, Merlin. Thank you.
Well, thank you, Garry, and thank you to the Heart Foundation for knowing what a nephrologist knows, that the kidney is the most important organ in the body. But the challenge really about the kidney is that most people don't recognize it as a problem because of its knock-on effects. And one of the critical ones is a knock-on effect on the heart. The kidney supports the heart in many different ways. And so when that support is gone, it's very difficult for people with heart disease to function. And that's why critically supporting the kidney means supporting the heart, as you'll hear through this symposium. But this cartoon really summarizes the challenge of when you find someone who's got chronic kidney disease, they're in a very difficult place. It's very challenging, it's very dark, the risks are great. And often the general practitioner, the cardiologist, the nephrologist, the endocrinologist look at those with kidney disease going, well, what can we do? And what's really exciting is that there's some new therapies, and we'll talk about this tonight, to make real differences to the lives of people with chronic kidney disease. Critically, chronic kidney disease really means that someone is at high risk for heart disease. And in fact, if you look at the major reason for someone with chronic kidney disease ending up in hospital, it's actually problems with their heart, fluid overload and heart failure, having a heart attack, a stroke, sadly dying prematurely, the sudden cardiac death, having peripheral vascular disease. And if they can survive all of those things, then some of them end up on dialysis. But almost 99 times out of 100, if you have someone, let's say age 70 with renal disease, it's the heart that will be challenging them the most in that situation. This is the real picture of chronic kidney disease, and you can't really see chronic kidney disease until you look for it and see its manifestations. And it's now recommended that because you can't ask a patient, do you have kidney disease, or they can't feel any different until their heart problems start emerging, it's now recommended that everyone with either diabetes or who's obese or who's hypertensive, particularly those with heart disease and heart failure, and potentially Indigenous populations, should all be screened regularly for chronic kidney disease. And what that means is looking at the functions of their kidneys. And if you imagine the functions of the kidneys are kind of like the functions of a sieve that you might use to sieve your pasta. If your sieve doesn't work, it could not work in two different ways. One is the sieve's got holes in it, and so your pasta ends up in the sink, which is a mess. The other one is that the sieve doesn't work by not sieving all the fluid out, so the fluid is retained on the top and your pasta gets soggy. Both those things happened in people with chronic kidney disease, either manifested as albumin in the urine, in other words, pasta in the sink, or reduced filtration, in other words, a reduced EGFR. And when you look at cardiac problems, whether it's cardiac death, whether it's a cardiovascular event, whether it's hospitalization for cardiac disease, as your kidney function declines from the left to right, you are far more likely to be developing problems with your heart, and particularly serious problems with your heart. And the same goes for albuminuria. If you've got more albumin in your urine, if you've got a moderate amount or you've got a severely elevated amount, your risk in this case of cardiovascular mortality is markedly increased, up to 3 to 4-fold higher than someone without chronic kidney disease. And really what the kidney does in those circumstances, it's not just a marker of other problems going on, but the kidney really is a lifesaver for the heart, particularly stopping the heart from getting into a cycle of fluid overload and becoming decompensating, either ending up in hospital with a cardiac event, heart failure, or dying as a result of cardiac stretch. And so when you look at whether it's, in this case, hospitalization for heart failure, those people with more reduced kidney function, those people with higher amounts of albumin in their urine are far more likely to be hospitalized for heart failure than someone without those levels of kidney function. Equally, when you look at patients specifically with heart failure, as your kidney function declines on the right to left, the risk of all-cause mortality goes up and up and up and up. But when you look at the kind of reasons why people with chronic kidney disease dying, it's those big bars at the bottom: death due to heart failure and sudden death due to another kind of decompensation. The heart decompensates and triggers a fatal arrhythmia. And those are the critical things that kidney disease means. And that means protecting the kidney means protecting against fluid overload, heart failure, and sudden death. And that's why we've now got in Australia and globally these categorizations, whether you've got high amounts of albumin or low amounts of kidney function. If you get into those orange and red zones, just like the bushfire warnings we have around in Australia, you're in critical danger and you need to act, really stop, watch and act, as we do here in Victoria, to really deal with these challenges. You can't just go on without it because something will happen. And it's really important to know that there are opportunities now to make a difference. But it's not just the albuminuria and the GFR that matters. In fact, when you look at following people through time, if people are losing kidney function, even after you adjust for the level of their kidney function or their heart disease or other kinds of things, if they lose kidney function, which is on the left side of each of these graphs, you're more likely to end up in trouble, whether it's death on the left side or cardiovascular events on the right. If their kidney function is failing, then actually so is their heart, which means that you need to do something about it. But critically, if their kidneys are the lifesaver for them, it's so important that the Heart Foundation and you as practitioners start saying, if we can protect the kidneys, we can actually protect the function of their hearts and prevent them from decompensating. And we know this from trials now that have been undertaken, for example, in patients with diabetes, where if you take the association between albuminuria and, in this case, cardiovascular death, it's pretty linear. The more albuminuria, the more the risk. But equally, when you treat them and you lower their albuminuria as a result of their treatment, you assume the risk of that lower level. So if you can protect the kidney, lower albuminuria, slow the decline in GFR, you can really protect the heart and important things like cardiovascular death. So I hope I've been able to, in a little rushed 8 minutes, tell you how that recognizing that heart, kidney and kidney disease are really common companions. And that's why really we're talking at this symposium, and that the kidney really makes a big impact on the outcomes, the hospitalization, the treatment response, and the survival from heart disease. And that's why it's so important to screen for kidney disease in anyone with heart disease. And then when you identify someone with or at risk of kidney disease, actively try and protect the kidney in those situations. And Professor Bakris is going to talk a little bit about how some of these new treatments can protect the kidneys in this setting. Back to you, Garry.
Thank you very much, Merlin, and you've set the scene beautifully. You've also set the scene for the obvious question, what do we do about it? And I can't think of anybody to tell us better than that, better than George Bakris about therapies for managing cardiovascular risk in kidney disease. George is up very early in the morning in Chicago, so we're very grateful to have him at all. But I certainly know that he will give us a very up-to-date presentation on where we are with present therapies for CKD and lower cardiovascular risk. Thanks, George.
All right, very good. Merlin, thank you very much. I want to say something before I get started here, because I'm going to talk to you about how to really protect the kidney and guidelines. And it turns out things that protect the kidney also protect the heart for the most part. The kidney and the heart you should think of as a married couple, a happy married couple that work together to help each other out. And when one can't help the other one out, there are major consequences for both. And Merlin, I think, did a great job of setting the stage for you. I'm going to talk to you about blood pressure goals, lipid goals, and how those play a role. Now, this is from the guideline, the American Heart Association, ACC guideline, that basically says that if you're at greater than 10% cardiovascular risk over 10 years, you should have a blood pressure of less than 130/80. Now, if you want to be a trialist and say, well, do the clinical trials support this? Well, the bad news is not really. They support a 15% 10-year risk. You should be at less than 130. But there's some epidemiology that goes into this. And I think this is a good rule of thumb. It's conservative and makes the point because many people don't get below 130 anyway. Now, is everybody on the same page? Well, they're not. The European guidelines, and this is a synopsis that I was asked to put together, comparing European guidelines and American guidelines. And you can see that the guideline goals are a little higher. They're more traditional. Okay, so this, I'm at the guideline slide here. Yeah. You can see comparing, I've enhanced for you the office and the home blood pressure. Home blood pressures are critical. More important, I would argue, than office. And if you teach the patient how to take home blood pressures, they're validated against office blood pressures. And so you can see what the goals are here. They're not that different, but they're still different. And I think it's important to understand why these numbers are the way they are. But clearly, nobody's being very liberal about it. They do want the pressures more aggressively controlled. Now, the Australian blood pressure guidelines is a nice little thing that I saw here that John Chalmers and group put together. And they recommend drug initiation with low CV risk, and they define low CV risk when the pressures are greater than or equal to 160. Clearly a different interpretation. And for those at moderate risk, so there's the 10 to 15% that what I was talking about, 140, much more aligned with the European guidelines. And then the target BP should be less than 140 for everybody with a history of chronic kidney disease, peripheral vascular disease, diabetes, and stroke. Now, having said that, I think it's important if you've got a, interestingly, very high risk, greater than 15% 5-year risk, and that includes all the populations I just talked about, they're talking about pressures of less than 120. So again, this is a little off the beaten path, but I think you can see around the world, different people interpret the same data a little bit differently. Nevertheless, I think it's important, whatever data you want to figure out here, that the data do support being a little bit more aggressive if you're at higher risk. That's one thing that is consistent. And again, for the elderly, keep in mind, you have to be practical here. You can't really get pressures way too low. There are data, if the arterial system allows you, in other words, if they don't have a huge pulse pressure, you can get the pressure down to 120 and you'll be in great shape. But most of the time, if you can get them below 140, that you're definitely doing them good. and less than 130 is even better. So there it's what the patient's physiology will allow. It's important to take off his BPs appropriately. You don't have them rush in, slam the cuff on over the clothes, check it real fast, and you think that's the blood pressure. It's not. There's a formal way of measuring it. They need to be formally seated, back supported, feet flat on the ground, arms supported, and they need to sit there for 3 to 5 minutes before you do anything. And then you should check 3 pressures, eliminate the first, average the second and third, and that's closer to the truth of what the blood pressure is. In this way, you'll get rid of white coat hypertension and a lot of people that are very anxious and be treating the right people. So the other thing you need to do is you need to modify risk factors. And you all know the risk factors. They're the same as that for the heart, as I told you earlier. And I've just listed them here. And that's got to be a huge factor. You need to tell the patient that you're the teacher, they're the student. If they are a good student and they follow what you say, life is good. If they don't follow what you say, then the consequences are theirs, not yours. And that really resonates. I ask the patients a lot of times, were you good in school? And if they say yes, I said, well, we'll be fine. If they say no, I said, well, now's the time to become good. Otherwise, you're going to pay for it. And I tell them what the consequences are going to be. So I think this is important. Now, this is something that I was asked to create for the JNC7 that came up again in the ACC guideline. And this is critical. And I think you should share this with the patient, not in this form, but you should share what specifically the patient can do to control their blood pressure. And clearly sodium intake is critical, but also potassium intake. And if they have kidney disease, that's a real problem because they can't take in large amounts of potassium. The kidney handles 90% of the body's potassium. BP thresholds, we've already talked about and what you should do. But basically, anything with a pressure above 130, the American guidelines would say you need to treat with at least one medication and lifestyle. The European guidelines say lifestyle until you're over 140. So it depends on who you want to believe. But it is important to rule out white coat hypertension and mast hypertension. And mast hypertension is when the blood pressure is high outside the office. In the office, it's normal. You can only do that with ambulatory blood pressure monitoring. And the bad news is we don't have any outcome data with this because it's very hard to detect. Although we do know the people that have been looked at don't do well. And these are generally job and stress related. And so you need to understand that. This is the European guidelines in terms of single pill combination. So the European guidelines, you start with 1 pill, 2 medicines, because that way adherence is a major problem. And this way you get over it. If they're willing to take 1 pill, they at least get 2 medications. And this mindset has been around in other parts of the world as well. I bring up kidney disease. I bring up kidney disease. If you look in the middle, it tells you specifically, Merlin set this up nice. It tells you specifically, you need to measure not just GFR, but you need to get the product of the kidney. What's that? Urine. You need to look at that and look at how much albumin is in there. And if it's more than 300, they've got kidney disease big time. And you need to put that together, that nice little box he showed you, that heat map of different colors. You need both the albuminuria and the GFR. Otherwise, you really won't know where you are on that map. So that's why you got to measure both. It's a big, important issue. Now, when we look about the ESH guidelines, only discuss CKD as a risk factor. They don't discuss it at all. And they say get it below 130 for cardiovascular risk reduction. There's no data supporting further slowing of progression of kidney disease at a blood pressure below 130. So you got to get it from 4 randomized trials. If you can get it below 140, close to 130, that's as good as you're going to get to slow kidney disease progression. However, there are data in people with kidney disease that if you get it lower, you will further reduce cardiovascular risk. So this is important to try to get the pressure below 130 to reduce cardiovascular risk. And SPRINT is the data this is coming from, except bad news, these are not people with diabetes, these are people with kidney disease from other causes. So the ADA, American Diabetes Association, has statements on blood pressure, and they, I would say 96% agree with the AHA guidelines, and they also agree with all international guidelines, Canadian guidelines, and even Australian guidelines, as I just showed you. If you have diabetes and hypertension, you want to be below 130. And the level of evidence is here. It's pretty straightforward. And you must be on a blocker of the renin-angiotensin system. And we're going to find out, hopefully, that you need to be on an SGLT2. And if you really have advanced disease, and Merlin told you, these are people that are going to get heart failure. The new class of drugs, the non-steroidal mineralocorticoid receptor antagonist finerenone, has also been shown to reduce the risk of heart failure in that setting, as well as kidney disease progression. So we now, like heart failure, have pillars of therapy we can depend upon to protect the kidney and the heart. The new consensus report, which is going to appear in Diabetes Care and Kidney International next month, is going to have a kumbaya moment with the diabetes guidelines and the kidney guidelines, all saying the same thing, that basically this pillars of therapy concept needs to be adapted. Blood pressure needs to be less than 130/80. This is the European guidelines, just to show you the difference. So you have the different cells with different diseases and what the target goal should be depending on your age. So clearly, this is something that is identified and pretty consistent with many guidelines. Now, what about the lipid guidelines? Well, the lipid guidelines were summarized, updated a couple of years ago. And you can see here that their top 10 take-home messages. First is all individuals emphasize a heart-healthy lifestyle. I mean, that's not a big surprise. The other issue is patients with atherosclerotic CVD should have a reduced LDL with a high intensity statin or maximally tolerated statin, if you can't do maximum tolerated. Very high risk, LDL should be less than 70, and the addition of non-statin therapy to statin therapy. In patients with severe primary hypercholesterolemia, then basically they need 10-year ACVD risk beyond a high-intensity statin. So that's when you get into more specialized therapies. In people that are 40 to 75 with diabetes and LDL greater than 70, start a moderate intensity statin without calculating a 10-year risk. Basically, it's the same kind of thing here. You can see that statin therapy in anybody at high risk, if you have diabetes, if your lipid levels are elevated, regardless of whether you have diabetes or not, you need to be on a statin and or ancillary therapy. And there's a number of therapies that can be added, clear evidence of ezetimibe helping statins. And we have a whole bunch of other agents that are new. But basically, the risk calculator there is important to figure out where you want to be. But this is just more of the same, and just very specific. Again, I think nephrologists generally don't pay too much attention to statins, and yet there is a trial, the SHARP trial, which has some evidence, weak, but some evidence that at least in stage 3 CKD, it does slow progression of kidney disease if you treat the cholesterol. So again, very important concept that I think you need to know. So I'm going to finish with that, and now we're going to hear more on this whole broad spectrum of the married couple of the heart and the kidney. Thank you.
Oh, thank you very much, George. I'm sorry about those slides, but I think we got the message very clearly, and in the end, they were very obviously visible to us all. We're going to move now, and we know there are special vulnerable populations as far as both kidney disease and cardiovascular disease is concerned, and none more so than First Nations people. And although we'll be addressing mainly Australian First Nations people, I think a lot of the information you'll be receiving is very applicable to those of you watching from New Zealand, the United States, Canada. Around the world, Indigenous populations are facing much higher risk, and William Majoni is going to tell us about that. William is a nephrologist working with First Nations people in the Northern Territory, and he has a broad experience in the association, not just the association between chronic kidney disease and cardiovascular disease in this particular population, but also what measures can be made to achieve satisfactory and effective management. So thank you very much, William.
Thanks, Garry. Thanks to the two first speakers. I think they've had a good roadmap to what I'm going to say here, and most of what has been presented already applies to the population that we deal with here, except for a few things that I'll show you in a minute. Kidney disease is very common amongst the First Nations, not only in Australia, but across the whole world. If you look at this data, which is from ENS data a few years ago, shows the prevalence of dialysis-dependent patients by states in Australia, and the Northern Territory is way above everywhere else. And if we are going to plot this to 2022, we're actually starting between 6 and 10 patients on dialysis every month here in Darwin. And most of this is driven by the high prevalence amongst our Indigenous population. This is the latest annual report from ENS data. The key messages I want to bring across here, if you look at the Northern Territory, you can see Western Australia and South Australia have got high levels as well. This is age-specific incident rates for treated kidney failure among Indigenous Australians. You can see that it occurs mainly in young people, 24 to 60 or 74-year-olds, but once you get to over 75, the incidence rates are the same. So it occurs in younger people. We talk of 40-year-olds and 65-year-olds in the previous data when we're looking at risk, but here the risk occurs in lower age groups. And that is actually mainly driven by social determinants of health. And I'll show you some information on that. It's very interesting that when you look at chronic kidney disease before they get onto dialysis, the rates are almost similar amongst men and women. But when they are on dialysis, you can see that we have got more women than men, which is very different to what we see in other populations where more men are on dialysis compared to women. And recently, with the new data systems that we have, we've actually identified that one of the major reasons for why this happens is that many men are dying from cardiovascular disease before they start dialysis. So it's not because women are weaker here, it's because they're actually stronger. They are surviving the onslaught of cardiovascular disease up to when they get onto dialysis. So this is a very interesting one, which has been bothering us for years to understand this. But now new data, which is not published yet, is showing that it's actually cardiovascular disease, which is killing a lot of men before they get onto dialysis. If you look at the prevalence of these selected conditions amongst the Indigenous people with and without kidney disease, you'll find out that cardiovascular disease is one of the leads, followed by diabetes. So the deep green is those with chronic kidney disease. The light green is those, light blue, sorry, is those with no signs of chronic kidney disease. Diabetes, high cholesterol, and cardiovascular disease are the leads. So diabetes and high cholesterol are very common here. A recent study published by our diabetes group here has shown that younger and younger people are developing type 2 diabetes, which is going to create a tsunami of chronic kidney disease and cardiovascular disease just in the near future. If you look at remoteness, we have very remote areas here in the Northern Territory and in the rest of Australia and other places where First Nations live. You can see that the incidence rates are directly related to remoteness. So the further away people are from major cities, the higher the rates. And this is really related to poor living conditions, to poor incomes. And I'll show you some of the data to support this. And this is one of them. just selected socioeconomic indicators amongst indigenous people, which shows that the rates are actually much higher amongst unemployed indigenous people, or those who have got lower educational levels, or those with lower personal incomes, or those with the lower household incomes. So it's actually a disease of poverty, a disease of poor socioeconomic exposure, which correlates with the high cardiovascular disease rates that we see amongst indigenous Australians. And if you look at the primary renal disease in most of our patients, it's actually diabetic nephropathy. In fact, the other day I was looking at our data for the 400 or so people who are on dialysis just in the top end here, and around 80% had diabetes as one of the comorbidities, which indicates that it's actually one of the main drivers, because diabetes itself is also a big risk factor for cardiovascular disease. And if you combine that with chronic kidney disease and some of the other socioeconomic factors and increased rates of smoking, which are seen, you have a huge burden of cardiovascular disease. So there are some special considerations which come from this epidemiological data, that when you are looking at risk factors, you consider them at a lower age. So, and the cutoff age from the recent advice is actually 18 years, which is that considering people as at high risk from the age of 18. So they need to be, we need to start screening them for both cardiovascular disease and chronic kidney disease at that age, because intervention with all those measures that have been already mentioned will make a huge difference to progression. And as I showed you, a lot of these people end up on renal replacement therapy, and they live in remote communities, which makes it difficult for them to access care. So this is just the recent guidelines which show the different age groups and how frequent we should be monitoring them. And as you can see, the age group has dropped quite significantly for the reasons that I've mentioned. So this is from the alliance, which has developed these very useful guidelines, which I'm sure a lot of people in this group who are within Australia would have access to the guidelines. What are the enablers of effective management? The key one is improved access to both specialist and primary health care. We've got very good both First Nations controlled healthcare systems within Australia, particularly here in the Northern Territory, and outreach specialists going into communities working together. But the one key part is community ownership of programs as well, and introducing self-management programs which are embedded within the community ownership. And this is something which is really a new phenomenon, which is happening here, particularly here in the Northern Territory, where we have found that in communities where most patients work together with their First Nations controlled healthcare systems, with a lot of input from specialist services, the outcomes are different. And the key word is collaboration amongst all these services to implement all the guidelines that have been mentioned before. And to add to this, there's a recent guideline which hopefully will be released soon, which is specific for First Nations Australians. I think it also applies to Maori in New Zealand, which is very specific and includes how we can work together with the communities to help reduce the risk of chronic kidney disease and cardiovascular disease, which are, as was mentioned here, married partners which go together, one causing another and vice versa. Thank you very much.
Thank you very much, William, and that's a wonderful summary of what is a very sobering experience that people working in your area are facing. and thank you for the insights you've given. Now we're going to, firstly, just to remind you, please feel free to put your questions up on the Q&A section of your Zoom screen. We'd love to hear from you. We're going to make you do some work now. We're going to do some live polling, and in a moment, a couple of questions will appear on the screen, and we'd be interested in your response. There's no right or wrong answer. We won't be, that your responses are anonymous. We won't be coming back to you and saying, why did you say that? But we'd just be interested in which you see as the most important in terms of things in your daily practice that make you initiate pharmacotherapy, for example. Is it the EGFR? Is it the ACR? That's the albumin creatinine ratio. Do you see those as important? Lipids, blood pressure, glucose, or some multivariate risk score, which are used to a greater or lesser extent in different countries. Thank you. And then there's the second question about what blood pressure target you would aim for in your patient with chronic kidney disease. And let's, because I know you might be influenced by age, let's say in a 65-year-old. Okay, I think the results will appear in a few seconds. And there we go. People are certainly very much influenced by blood pressure. And all of these things, of course, are important, and all of them can be relevant. As far as blood pressure targets concerned, the majority of you go for 130 on 80. I don't know whether any of the panel want to comment on those responses. Perhaps George is nodding. I think he agrees.
Fully agree.
Yeah. Okay, we all got it right. Merlin, have you got anything you'd like?
All of the above.
Well, look, let's get practical now, because Alison Edwards is at the coalface in general practice in South Australia, and I'd be interested, Alison, in your reflections on these presentations and how you think they can be practically applied in primary care, and particularly how teams might be brought to bear on the complexity of the relationships between cardiovascular disease and renal disease. Thank you, Alison.
Absolutely. No, look, thanks, guys. That's been really, really useful to, I think, probably remind us all of the importance of screening for chronic kidney disease as part of an workup for trying to keep our patients healthy. As a GP, we've got a mix of patients with chronic conditions like diabetes that we're trying to maximise their long-term outcomes, but also work with populations that we've known for a long, long time. We might have checked their EGFR at some stage, but do we think to do an ACR reading as well? The Heart Foundation Heart Health Check Toolkit runs through some really good ways of reminding ourselves to keep focus on all those sorts of things. And I know, Gary, you're going to give us a bit of an update on all the resources there, I think, towards the end. So I won't harp on too much for that. I think often being able to diagnose someone with early chronic kidney disease that without screening for it, you're not going to know that they've got it, can be a really useful trigger to start the conversations around more aggressive management of blood pressure and cholesterol. Often telling someone they've got blood pressure is a little bit meaningless to them, but telling them that their kidneys are failing is much more frightening to them. So it's a good reminder just how important the interconnection between chronic kidney disease and heart health can be.
Thank you. Let's go to some of your questions, and that was great. George, could you talk a little bit about diuretics and CKD?
So diuretics have an important role in CKD, and I guess I'll make the following statement, that if you're treating blood pressure, then as long as you got a GFR that is above 25, and you're not having other mitigating factors for volume overload, chlorothalidone, the longest acting thiazide type diuretic, is very appropriate. There's a recent study published in New England Journal called the CLIC study. And this was a single center study, but it actually specifically looked at people with kidney disease that did not have supervening heart disease. So they didn't have stage 4 heart failure or anything like that. It was strictly kidney disease. And chlorothalidone did a very effective job in lowering blood pressure and maintaining volume. Now, otherwise, people, so you shouldn't be rushing to loop diuretics, and loop diuretics are very different, but of the thiazide diuretics, chlorothalidone and indapamide have the lion's share of the data. Hydrochlorothiazide is shorter acting, only lasts about 14 hours with metabolites. And unless you're using very high doses, which are going to have a lot more side effects, it's not as good as the other ones, and certainly not on outcomes. Loop diuretics clearly have a role. And I guess I'd summarize it by saying torsemide, there's a very large trial. It was just finished. It's going to be announced as a late breaker at the American Heart Association. 6,000 patients randomized to Lasix versus torsemide on cardiovascular outcomes. And a lot of these people, I don't know the exact numbers, but a lot of these people have CKD. And so for me, my favorite loop diuretics, torsemide. Furosemide, I don't use so much. I do use bumetanide. And the reason for that is it is functional in low albumin states. And as any nephrologist knows, a lot of these people do have lower albumins because of proteinuria, and you'll get more diuresis. But that's my overview on that.
Great, thank you. Merlin, I wonder if I could tease you out a little bit on screening for CKD and where you see the role of albumin versus EGFR versus albumin creatinine ratio, and particularly in diabetic and non-diabetic subjects.
Thanks, Gary. The most important thing is that you do it. It's the greatest tragedy is that we often do it once and then maybe forget about it for a time, and then but if it's done on a regular basis, not only can we see what their level of risk is, but also we can see that maybe their kidney function is declining faster than we otherwise would like. And if they're losing more than, let's say, 3 mils per minute per year, so let's say they've gone 10 mils per minute per year, gone from 70 to 60 in 3 years, then they're going way too fast and they need to be slowed down. And when we talk about slowing kidney function, what we really mean from a practical point of view is, from William's point of view, it means time away from dialysis, but more particularly from a cardiology point of view, it's time away from heart failure, it's time away from fluid overload, it's time away from hospitalizations, it's time back with your family. So protecting your kidney just gives you that extra time. And the way to do that is by measuring the kidney function, as we do in people with diabetes, annually and serially, both GFR and albuminuria. And when you find someone with either elevated albuminuria or reduced EGFR, then you pull out all stops, because the number needed to treat to save a life, to keep someone out of hospital, to make a difference, is so much smaller in someone with CKD because their absolute risks are so much greater.
So is there an age or a point at which you think it's worthwhile screening all adults for these conditions?
Currently, it's not recommended to screen all adults. Usually there is some risk factor, but the truth is that so many of our older Australians are either have diabetes, are obese, have hypertension or cardiovascular disease. So the majority of them are warranting screening for kidney disease on a regular basis, as you would be screening anyway for diabetes, as you would be screening for hypertension or cardiovascular risk.
Okay, so how does that work in primary care, Alison, in terms of screening for kidney conditions?
Yeah, it's very easy to do a database search and just pull up who has or hasn't had their ACR done and their EGFR done in the last 12 months or so. You can use your tools like PenCS or even do a database search within your electronic health record. We've tended to go over 60s if they've not got other risk factors, but smokers, we're targeting at almost any age. And one thing that's probably not very clearly spelt out is whether the establishment of early kidney disease puts them into an automatic high risk, like if they've got proven end organ damage. I tend to treat them as if they are automatically high risk and not use the heart risk calculators. Is that a reasonable approach, Merlin?
Absolutely. I think that's a very reasonable approach to, if you find someone in the red or orange zone of the KDIGO stratification with albuminuria or reduced eGFR, then that's cardiovascular risk as well. What's really interesting, in the US, they've just announced that as a practice, as a way of looking at good and bad practices across the US, albuminuria is now being considered a good way of, if you're not doing albuminuria, you're a bad practice. And they're going to use that as a standardization across the US for good and bad care. So they're starting to bring screening for CKD, not just only requiring it, but actually as a way of paying people and paying doctors in the US. If they're not doing their job, they're not measuring albuminuria.
Thank you. So we've got a number of questions relating to ACEs and ARBs and even ARNIs, the drugs that are used in heart failure. Any preference for ACEs over ARBs, or for particular drugs within the class? And is there any evidence for ARNIs in CKD because they're so effective in heart failure? Might be one for you, George.
So the ACE inhibitors that have evidence behind them for anything to do with the kidney, there's not too many. Ramipril is probably the king that comes out amongst all the ACE inhibitors. On the other hand, ARBs, there's quite a few that have evidence. Losartan has it, telmisartan has it, and irbesartan has it, and valsartan has it. So for me, because I've got a lot of Afro-Americans that I treat, I basically avoid ACE inhibitors, and I just use angiotensin receptor blockers. The other thing that's not appreciated is in angiotensin receptor blockers, the blood pressure effect is different. And it's a function of A2 receptor binding. And so losartan has the weakest blood pressure effect, and olmesartan and azilsartan have the highest blood pressure effect. So is there any difference amongst the ARBs in terms of outcomes? And the answer is we don't know because it hasn't been tested, but I would argue that there is no difference because they all work by the same mechanism. So the key is people don't know how to use them and they're scared of them because of a slight drop in GFR. And I guess I'm going to make the plea, and I'm pretty sure Merlin's going to agree with me, that if you start somebody, let's say somebody has a GFR of 40, and you start somebody on, let's say, losartan at 100 milligrams a day, and the GFR drops to 36, but the blood pressure is controlled, you do not, let me repeat it, you do not stop the ARB. You continue the ARB because that's actually life-saving. And in fact, we just wrote an editorial with Matt Weir, another nephrologist, that basically summarizes all of the drugs that lower GFR initially that save kidneys, ACEs and ARBs, SGLT2s, and the new non-steroidal MRAs. So understand physiology. Don't be scared of numbers.
Yes, some of our favorite drugs drop GFR, don't they? William, you must see that a lot. And in fact, George, you've just answered one of the questions from the audience who says, I've noticed that hospital specialists often stop ACE or ARB medications if GFR drops below 30, even in diabetic patients with albuminuria. I think George has said that's not something to do.
But there's one study I want to point out, and it's a study that was published in JAMA Internal Medicine 2 years ago. And it's a database analysis, but it's a database analysis from a very large healthcare group here in the US, the Geisinger Health System, looked at just shy of 4,000 patients going out 6 years, specifically in people with GFRs below 30. and it looked at those that continued on an ACE versus or ARB versus those that didn't. And when you looked at ESRD and all-cause mortality, if you were continued on an ACE or an ARB, you had lower all-cause mortality and lower ESRD in stage 4 CKD. So no, don't stop it.
Okay.
But it is contentious, Gary. So I mean, this is the reason for the Stop ACE trial. The reason that they did that trial was specifically to say, should we be stopping it or shouldn't we be stopping it? That trial got weirdly extended for reasons that they didn't have enough events or they didn't accumulate. It was approved to be extended and it's still ongoing. It was supposed to be announced already. So the answer is it's still a little controversial, and that's the reason for the trial ongoing. By comparison, other agents in that same setting, things like SGLT2 inhibitors, really don't need to be stopped and are abundantly safer when it comes to things like hyperkalemia. When it comes to that drop in GFR, it's much less, and certainly it's only functional with an SGLT2 inhibitor, and it's much better tolerated in individuals compared to a RAS blocker, which can lower the blood pressure, raise the potassium, and drop the GFR.
But Merlin, I would say, based on exactly what you said, that the fact that trial needed to be extended because there weren't enough events was either the people designing it didn't know what the hell they were doing and it was underpowered, or it ain't so bad because you don't have enough events.
Thank you. William, I'm interested in your comments on this issue because it's a very common one.
Yes, it's a real challenge, as you may imagine, with the significantly high rates of kidney disease, people getting their ARBs and ACs stopped and started, stopped and started. I mean, there's some assumption that SGLT2 inhibitors are going to provide the magic wand, but I'm sure these questions will still be coming up. I think it's a common problem, and personally, I tend to encourage people to continue unless it's acute kidney injury. You can withhold for a few days and let things stabilize and restart again. But then when you restart, you may have a slow rise in creatinine. What do? You stop again? So this is why it's really important to have some clarity on continuing the medication closely, monitoring the patients, unless there's a really very severe loss of kidney function, in which case that question is probably irrelevant.
Thank you. Alison, you partly answered this one, but we've got a question about talking to about the prevention of CKD. What kind of risk factors are most associated with developing CKD? Which comes to what do you look for when you're looking amongst your own practice for people that are the most likely at risk, and of course not underestimating the importance of lifestyle factors in dealing with that.
And of course, lifestyle is probably the number 1 to 10 of your risk factors. And essentially the risk factors are shared across kidney disease and cardiovascular disease. So the modifiable ones and the non-modifiable ones really are almost identical. And I guess one thing that I was thinking might just be worth highlighting before we end up having to wrap up, because the kidney disease link with the cardiovascular risks is so close. One of the frustrations in general practice is we get rewarded differently for managing risk factors compared to managing health conditions. And so we can't actually put in a GP management plan or a team care plan for blood pressure or for cholesterol, but we can once we've got a diagnosis of heart disease or kidney disease. And so if you're seeking some inspiration or motivation as a clinic to try and find more of your chronic kidney disease, screening with your ACRs when you're doing your health checks will actually flush out quite a few early kidney disease, which then opens the door a little bit more to be able to get on board with some multidisciplinary care through the GP management plan and team care plan schemes, which is specific to Australia, but it's it's just one way of actually helping our patients get the supports that they need to help target some of the lifestyle factors that put them at risk for both conditions.
Thank you. We've got a number of questions about coronary artery calcium scores in people with CKD. I don't know whether anyone wants to speak to that. Certainly, as perhaps the only cardiologist on the panel, I'll say that chronic kidney disease is a very calcifying condition, not just the coronary arteries, but the rest of the arterial system. They also get more cardiac hypertrophy. I think if you've got someone with established, beyond a certain age, if you've got someone with any indication of CKD on the normal test, they're very likely to have a high calcium score. But I'd be interested in any.
Yeah, I mean, certainly one of the reasons for doing the score is to assess cardiovascular risk. And if your eGFR is already that low and you've got albuminuria, then the question is, why do you need to do that score to know that they're high risk? You should be already maxing out their lipid lowering, blood pressure lowering, SGLT2 inhibition, RAS blockade already, and the additional value of knowing that their vessels are calcified doesn't actually tell you anything more than that you already know that they're at high risk. The classic thing is that you can tell someone with kidney disease when they fall over and have their hip fracture because you can see their femoral artery running on the X-ray. Classically, as you say, vascular calcification is such a major component of their vascular dysfunction. But doing a score doesn't tell you anything more than you knew that they're at high risk.
Yeah, so I mean, it's stating the obvious, but the Heart Foundation's position on calcium scoring is the same in Europe as Europe and American recommendations. Don't do the test if it's not going to change what you do. If you're already going to go full on in terms of normalizing cardiovascular risk factors, then the calcium score is not going to tell you much more. We've got so many good questions. I'm not quite sure where to go next. We've got a question for comment on the sodium HF study, the sodium heart failure study.
Well, let me take a crack at that. The sodium HF study, the whole hypothesis was that if you lower sodium intake below what the guidelines are for that group, that you'd get better cardiovascular outcomes. I'm not really sure why they came up with that hypothesis, because it doesn't really make sense to me, but that they tested it, and guess what? It didn't work. But I think something that I learned back when I was a resident at the Mayo Clinic was, and with the way they treated heart failure patients back then, is they put them on a very low sodium diet. So instead of 2 grams per day, they had them on about 500 to 700 milligrams per day, almost nothing in terms of sodium. They were not delusional. They didn't think that that was going to reduce mortality or do anything like that. They did that because they wanted fewer hospitalizations. They wanted less volume overload, and that's it. And that's all you should expect. If you look at the levels of sodium they achieved in that trial, they're about double the level that they were using at the Mayo Clinic. So I'm not shocked what they found. I could have predicted that before the trial.
Okay, well, thank you. That's helpful. Look, we're going to have to close very soon. So thank you very much to the panel, and thank you very much for those wonderful questions. A recording will be available in the next few weeks, and we encourage you to complete the evaluation form. That'll pop up when this webinar ends, and that's a good way of getting your continuous improvement numbers too up. If you require a quick completion certificate, it will be available at the end of the survey. We've got a number of things. The Heart Health Check Tool Kit, which was referred to before, is available on the Heart Foundation website and will help you in terms of risk prediction, risk evaluation. We've got new lipid management resources that are available, again, at the same place. And the new thing to announce tonight is a primary care virtual roadshow, which will begin very soon in regional areas, and a number of, well, most PHNs around the country will be involved, and look out for those. we will close at this point. Again, this has been a wonderful session. We could have gone for another hour, I think, but please look out for future webinars, and thank you again to our panelists who've, I think, put a lot of effort and thought into in clarifying, what is potentially a very complicated area. Thank you all.